My name's Deborah. I'm one of the new head of neck CNSs for head and neck cancer at Royal Preston Hospital, Lancashire Teaching Hospitals Trust. So my understanding of shared decision making is ensuring that the patient is given all the information that they can make an informed decision to support their autonomy, and we as professionals should guide them and give them the right information so that they can make their decision about a certain situation. A couple of weeks ago, a lady came to head and neck clinic and she had quite advanced cancer to the floor of her mouth, and the consultant had previously given her the option of surgery, and it would have been curative surgery but quite extensive, and at the time she wanted to be able to speak to her family, go home and think about the decision. So she was given all of the information on that particular day, and then she was brought back to clinic. And when the consultant went through the process again, what the surgery would entail, the effects after the surgery, what quality of life would be like, she then said that she came to the decision that she wanted to decline the surgery, even though it would be curative, because she felt that the side effects would not allow her to have the quality of life that she wanted. So she declined the surgery. So I was there as a support to the lady, and to make sure that I felt that she was given all of the information to be able to make that decision. And then I was there as a support afterwards, after she told the consultant the decision that she wanted to make, and just to make sure that she felt it was the right decision and if she needed any more time. So she was given verbal information by the consultant, I think it was a week prior to her coming back to clinic, and he just ran through all of the steps of what the surgery would entail. So it was about how she would be able to verbally communicate following the surgery. The surgery would require for a large part of her jaw to be removed and to have a large resection. So the consultant explained to her that her verbal communication would be quite poor for the rest of her life, and that she would heavily rely on being tube fed as well. And it was the tube feeding more so, because she said that was eating and drinking played a large role in her life, as in a social aspect, and she felt that she didn't want that life for herself, and that was the main decision. In the second clinic when she came back, he said that she could have palliative oncology treatment, but other than the surgery she wouldn't be able to be cured without the surgical resection. Yeah, the consultant was actually very clear with her in that, saying if she, because that was something that I wanted to make sure that was put across to her clearly as well, and the consultant explained that not having the surgery would mean the end of her life, basically. Pretty well, I feel that it had a good ending, but in my previous role as a palliative care nurse, about a year and a half ago, I went to visit a lady who had lung cancer, and I first met her as an inpatient in hospital. I think she'd come in with a chest infection, and when I'd read through her notes on the computer, I noticed that her prognosis was, I think, about 6 months. And when I was talking to this lady about supports for her going home, I think she was only in her 60s, she talked to me about things about saving for a new kitchen and an extension on house, just different things that in my mind didn't sort of pair up with somebody with a prognosis of 6 months. So I explored that a little bit deeper with her, and I asked her if anybody had had a conversation with her about prognosis and if that's something that she would want to explore. And she was actually very keen, and she said, oh yeah, if somebody knows my prognosis, I would like to know. She was aware that she was palliative, but I think in her mind she was more years rather than months. And she was a little bit upset that she'd never had this conversation before, and obviously she'd been seen multiple times in clinic by her other consultant that dealt with her from a lung cancer point of view. So I spoke to a team, and I feel that sometimes in these kind of situations, I feel that a lot of teams are a little bit horrified at the thought of somebody being told the prognosis, and they were a little bit surprised that she would want to know that. In the end, we managed to facilitate a meeting with the lady, with the family, the consultant. We went through the prognosis with her, and she was relieved because it completely changed what she wanted from her life, and she was able to then make the decision that she wanted to go home, she wanted to be with her family. She wanted to get out of hospital as soon as possible. She didn't want to come back into hospital. So yeah, I feel that if she hadn't have had that conversation, then we would have failed it, but luckily we've picked up on that from that hospital admission. I feel that in nursing, you view the patient as a whole, and I think that we see them not only on this episode and what can we do for you in the here and now, but you think about the life as a person, the home life, what they want, the quality of life, and I feel that we're really honoured as a nurse to be able to look at that and think, how can I make this better for you? What's missing in your patient journey that can allow you to achieve those goals? So I feel that we strive to achieve shared decision making, but I know, and I'm guilty of it myself, that we do fall into guided decision making some of the time. Yeah. Again, probably my palliative care nurse role, if an elderly person who lives on their own wants to go home and they've had, say, multiple falls, they're rapidly deteriorating, they may be what's known as a fast-track patient, so we feel that they're likely to have a prognosis of less than 3 months, and from experience with our professional heads on, we know that they are just going to continue to rapidly deteriorate, and if they're having multiple falls now, in the future something like that's just going to get worse and worse. Some of the patients that have been in a similar situation to this, they may not have a lot of family support, they may have a carer that can come in a few times a day, but that's it. And when that person says, I want to go home, absolute alarm bells ring for us, and we just think, oh, this may end badly for you. And we do try and guide them to see a safer option, which may not be right for that person. They know what they want for the quality of life, but I think we just look at safety and trying to do what we think is best for them, which may not always be the right thing. So I think tip number 1 is not to use jargon and to speak to a patient on their level. Like you said before, a lot of patients don't know what the term palliative means, making sure that maybe asking them to feedback their understanding to make sure that we're all clear and that we're on the same page. I think the second tip would be to give the patient time, because I know that patients may make a panic decision. If they're feeling very overwhelmed, they might say, no, I don't want any further treatment, for example, but allowing them to have that time and that space to go and speak to the family, to the loved ones, they'll sometimes come back with a different opinion. And I think that the third tip would be not to judge that person, not to do what we think is the right thing. It's to explore that quality of life, like the lady with the prognosis. I think that somebody had made a prejudgment that lady wouldn't want to discuss something like that, whereas I think it's not that you want to force, no, you must talk about your prognosis, but I think it's just giving somebody that opportunity.